Welcome to the CVI meeting. We are in the most exciting track. You know, we're competing, unfortunately, with 3 other tracks. Amongst interventionalists, it might be hard to attract heart failure-specific interest, but we'll give it a try. We'll kick it off, and it appears to be a TED Talk style, Dan, so get ready for it. We're going to start with Dan Burkoff, talking about the state of the art of emerging technologies in heart failure interventions. My name is Marat Fudim, and I'm joined by Michele Esposito. She is at USC, I'm at Duke. We will be your chairs for the first 2 sessions today.
So, heart failure is a chronic systemic disease, as you all know. It affects, starts at the heart, but then almost all the organs of the body are affected. And the autonomic nervous system plays a key role in this, in the pathogenesis and the progression, as well as increasing recognition of the role of inflammation. So there are many, many targets for treating heart failure. And of course, we have the pillars of medical therapy, but as we all know, despite the best medical therapy, there is this progressive trajectory that patients take. And most patients, especially with heart failure reduced ejection fraction, succumb to heart failure, which is not exactly the case with heart failure preserved ejection fraction, where less than half of patients die from heart failure and patients die from other factors. But between this gap, between where drugs start to fail and at the very end, there's this gap. And this is generally the gap where devices are used. And we now have, you know, over the last, since the late 90s, so we're talking about 25 years of innovation, we've got these basic devices that have emerged. And it always marvels me that, you know, in heart failure, we have a few devices, whereas like in interventional cardiology and structural, there are hundreds of devices that have been approved. And we're relatively limited with CRT. We now have TEER, which is structural, pressure sensors, and CCM and baroreceptor activation therapy, which have not really penetrated. Neither of those therapies have really penetrated into the market yet, have not reached their full potential. But still, this is an area of a lot of innovation. And this target, which is really mainly in the class 3, patients with persistent class 3 heart failure. So what are the devices that are either tried and true or under investigation? Well, of course, we have CRT, and now there's the potential that that's going to be replaced by conduction system pacing. And probably within the next few years, there'll be results of trials that are going to compare these and tell us. But here in electrical therapies, we have CCM, and coming out very soon, next year, will be the combined device with CCM and a defibrillator. And now for patients with narrow QRS, this may be more attractive for those patients. In the neuromodulation realm, we've got really the only one of these that's really existing that has any uptake is the baroreceptor therapy, the CVRX. Renal denervation for this application is still under investigation, and these other devices that are intended to also fake out, to modulate neural system are still, you know, have really come and gone pretty much. But nevertheless, they have a place in history because the autonomic nervous system is a really viable target for treating patients. Remote patient monitoring, of course, there's been a huge advances in the devices that actually are the sensors. A lot of opportunities now for sensors, and what's really going to come is how is all that information going to be used, and here's where AI is probably going to play an increasing role in addition to in addition to trials that are going to show taking the physician out of the loop and having patients do self-management. That's really clearly going to be the future to try to you know, make these more applicable and more broadly used without burdening the healthcare system. Inter-atrial shunts, there are now all of these devices and procedures that are under investigation. We have two trials that have failed their primary endpoint, and one of these trials, the Corvia study, is now nearing completion of enrollment in a confirmatory trial, and the V-Wave has completed the trial with a signal in the heart failure reduced EF, and with a signal of harm in patients with HFpEF. So we'll have to see where that therapy goes. But these other devices are still under early investigation. Ventricular reconstruction and reverse remodeling devices. These are devices that are trying to take large hearts, heart failure reduced ejection fraction, and the simplistic thinking, you have a large heart that should be smaller, let's make it smaller in one way or another. This is also approaches that have failed from the surgical approach, and also some devices that have tried to achieve this that also were not fully successful. But now we have three of these devices are in active discussion. The BioVentrix, which is in the middle one over here, I think is gonna be revitalized. They also have stalled in their clinical development, but we have the Ancora and the Carillon devices, which are actively enrolling patients. The V-Sling is a little bit more further behind, but nevertheless offers an interesting option. In terms of decongestion therapies, both for right-sided failure and left-sided failure, we have a class of multiple devices that fall under this classification of the DRIPS classifications that are attacking congestion from very, very different approaches. Early signals in feasibility studies show that almost all of these devices in the pilot trials can increase urine output by about 100 to 300 cc's an hour while they're being used without impairing renal function. So offer a very different opportunity compared to diuretics. And all of these studies are early in the pilot phase, and I think the challenge here is going to be on the regulatory side. What is the right pathway? What's the right clinical strategy to prove that these are helpful, useful, and that clinicians are going to want to go through the risk associated with large bore access to either the venous system or to the arterial system. And that is going to be a very, it promises to be a very exciting, era of device development for these patients. A lot of activity in this field with at least 8 devices that I'm counting that really show great potential. Of course, there's a lot of activity in percutaneous ventricular assist devices with the huge success now of Impella. There are a lot of innovation, not only within Abiomed, but you've got the Supera, the Magenta, which are now nearing a start of entry into the cardiogenic shock space. Those 2 devices are firmly in the high-risk PCI realm. But we also Cardion. There's also the Vitalis and the Venstra, which is maybe not yet in clinical trial, but all these devices really are showing the great interest in this field now that we have one positive study that with the dangerous shock study showing us that these devices, this class of devices, really has the potential to improve outcomes, and we're just really at the tip of the iceberg. We've got a lot of work to do in cardiogenic shock, and that will, of course, be very exciting. And now, after a period of a lull in innovation in durable ventricular assist devices, after the demise of the HVAD and the dominance now of HeartMate 3, over the last few years, there has been a really a nice uptick in, we'll call it innovation, although you see here there's a lot of copycats to HeartMate 3. A lot of these devices look like the HeartMate 3. Some of them don't. Some have unique mechanisms of action and offer some potential advantages, though that remains to be seen. if any of these devices can offer an advantage over what is now really, a fairly good device, and the remaining issues of driveline infections. We don't have fully implanted devices at this point, but that's really the question: is can we break the current barrier, which with the Momentum 3 results really showing really good 5-year outcomes that are comparable to transplant? How are we going to move this field forward in a practical way?
Dan.
And then, yes.
The timer. I thought time is valuable in New York.
This is the last slide.
Let's wrap it up. Good.
We now have the total artificial hearts, which are now maybe potentially making some kind of a comeback with the recent implantation of the Bivacor system. So emerging technologies in heart failure and innovation is alive and well. It's a challenging field. It takes a long time for these devices to go through trial and get approvals, and then even a longer time for them to be adopted by the heart failure community, which has very, very high standards. But along with all this innovation, there are new opportunities for career in interventional heart failure because someone's going to have to put these in. And as we know, the number of people going into heart failure is decreasing. But there are clearly a lot of opportunities for this. So thank you.
Thank you so much, Dan. For our next talk, we're going to be introducing Dr. Brandon Jones, who's going to be discussing ventricular reshaping. As a reminder, we're doing mostly 5-minute lightning talk style, and we're going to save Q&A for our larger chunks of discussion session.
All right, thank you very much. All right, so as an interventional cardiologist who stumbled his way into the heart failure room, I think this is a really exciting field.
Welcome.
And so, like Dan had explained, obviously, despite really excellent medical therapy that's been developed with medications, mortality remains real high in the heart failure population. And we see, 20% 2-year mortality despite 4-pillar GDMT. The COAP trial, you saw almost 30-year mortality despite effective TEER. And so, obviously, there are more interventions and innovations that are needed. And so this is some work that Dr. Burkoff's team did, showing that if you can do therapies that reduce volumes or improve ejection fraction, that you have a favorable impact on mortality. And you can do that by biological means, where you try to induce some form of either neurohormonal changes or affect the pressures by doing some sort of pressure volume reduction. And then that involves a biological, histological change in the cells. Or you can do something physical, where you're actually trying to physically change the ventricle and then see if the biological process will follow. And boy, there have been a lot of things that have tried over the years, and these are just like a slew of surgical and other transcatheter attempts that have made to try to affect this. But if we focus on ventricular reshaping, so if you think of physics real briefly, so the law of Laplace will tell you that pressure generation is going to be proportional to wall stress times thickness divided by the radius of the LV cavity. So for any given ventricular pressure, myocardium is going to be under greater stress the more the LV dilates. And reverse remodeling has always been a surrogate for success in these heart failure trials, but what if we also target the reduction in LV size to reduce wall stress directly? And so that's the concept for the AccuSense device. And so this is a transcatheter placed device where you come up through the arterial system across the aortic valve, and you wrap underneath the mitral valve behind the LV apparatus, and you place a series of anchors in the left ventricle with spacers in between, and then you cinch the ventricle in. And here's an animation that shows how this is done. And this is a procedure that's done by a structural heart interventional cardiologist under transesophageal echo guidance. It's and that's a depiction of all those different spacers, and then you apply tension on the cord at the end of the procedure. And what you see is you have a fairly acute reduction in LV size. But what you also see is over time, if you CT these patients, it's not just the 1 centimeter below the mitral annulus that reduces, the entire LV volume reduces over time. So indicating that you truly are creating some sort of a change in the biology of the patient by this acute ventricular size reduction. And this is data from the early feasibility, about 50 patients, showing that you have an acute reduction in volumes and an improvement in ejection fractions. But if you follow those patients out over 2 years, that those changes get even better the longer you look, and they sustain over time. And so the pivotal trial is the CORE-CINCH heart failure study, and that trial just hit an important landmark, 250 patients enrolled, which is the first FDA look. So in about 6 months, we might have some of our earliest outcome data from that trial. And the total enrollment is going to be 400 patients, so we continue to move towards that. But we're very honored to lead U.S. enrollment for that trial at our site at Providence in Portland. Another device that's in active clinical trials is the Carillon device. And so similar idea, more of an annuloplasty. This device is placed through the coronary sinus. And both the AccuCinch and the Carillon devices were initially designed to target mitral regurgitation. The AccuCinch device pivoted to be more of a pure dilated cardiomyopathy trial, but the Carillon device is still kind of doing a hybrid trial mechanism where they're looking at both MR reductions and heart failure reductions. Again, meta-analysis from some earlier data showing that the device has been effective in improving volumes, in improving 6-minute walk times. This is just a procedural example. Basically, you do a coronary angiogram. You demonstrate that the coronary sinus is not crossing at an unfavorable spot with relationship to the left circumflex. And then you place this device in. There's a distal anchor that is put in. You see that being deployed. And then there's you apply active pressure on the device, and that creates this annuloplasty effect. And then you deploy the more proximal anchor, and that's what holds this annuloplasty device in place. Then you do a final angiogram to show that you haven't caused any pinching of the circumflex artery. So again, this is in a pivotal trial, and targeting 300 patients, and we're actively enrolling in this trial as well. And then just a brief mention of the Revivant system. And so this is what Dr. Burkoff was alluding to. This is a device that is both placed either surgically or kind of a hybrid transcatheter surgical procedure, where you're basically trying to just pull the left ventricle aneurysm portion in. And that they were going to pivotal, and I think they lost funding, but my understanding is that they're trying to revive the technology. So that's all I have. And if you are interested in learning more about the AccuCinch, I did one of these Southwest Angio Club webinars with Tom Wagner and Mark Benares and Joe Walsh and Aidan Rainey recently. So if you want to hear a whole hour about AccuCinch, that's a good place to find some more information.
All right, next up is Dr. Emani from Cincinnati, who's going to be talking about inter-atrial shunts.
All right, thanks.
In 5 minutes, right? In 5 minutes, right?
In 5 minutes, right. So intra-atrial shunting, as Dr. Burkoff mentioned, there's been a lot of work in this space. Not all of it has yielded fantastic results, so it really lends itself to further investigation. We all know this. But I think a couple of seconds just to hit upon the fact that if you're not really thinking about heart failure on a routine, sort of every day, all night basis, many of our colleagues they refer to us for congestion, but pressure, volume, and diuretics, there's a lot beyond just that. And I borrowed this slide, but we know these patients are short of breath. A lot of times we'll look at them and say, oh, look, they're diuretic, naive, diuretic, undertreated, whatever. We get rid of volume, they feel better. But at the end of the day, a handful of them will show up to us again saying they're still short of breath despite being volume optimized. And these patients represent a really unique challenge. And for those shifting over to the pressure overload side of things is really where we're trying to target. And that goes back to the now universal definition of heart failure that talks about not just, again, congestive symptoms, but really the physiologic underpinnings. So here's that universal definition. And we know, and if you really think about that or translate that, abnormally elevated filling pressures leading to symptoms satisfies that definition. Typically, these are abnormal filling pressures with exertion or exercise. Borrowing from Dr. Adamson's now very well-known triangle progression, if we talk about these patients who have worsening symptoms with effort, but not necessarily volume overloaded, not necessarily coming into the hospital, another way to think about that other graph that was put up earlier, meaningful area of intervention. So thinking about this physiologically, right, left atrial pressures go up for a variety of reasons. That then pushes back on our pulmonary system. We get pulmonary hypertension, either a true post-capillary or a CP-CPH pattern. And ultimately, this is what leads to patient symptoms, both in HFrEF and in HFpEF. So what if we target that a little bit more directly? So you look at this way, and we just know that that's what happens, right? A lot of these patients have some degree of pulmonary hypertension, a not ignorable amount is in a combined fashion. So if I put my interventional hat on and say, look, I want to think about things as simple as possible, pressures are high, decrease pressures, make the lungs feel better, patient feels better. The concept is really, really simple. So, you know, how
Thanks
do we
for breaking it down?
You got to break it down to simple stuff. So, you know, how do you think about shunt devices? You can think about it in a couple of different ways. You can think about the anatomical target where we create a shunt, whether we leave a device behind or not, and then what is the target population. And there are studies sort of really trying to dissect which of these will respond into what type of therapy. So looking at this, the typical or the prototypical is the inter-atrial shunt in the inter-atrial septum. You know, born from the atrial septostomy stuff way back when for pulmonary hypertension and now becoming more mature. There are a variety of different devices and then subsequent trials looking at intervening upon that intra-atrial septum. There are a couple of unique devices looking at changing the direction of the shunt from the left atrium into the coronary sinus, which may provide a little bit of a different secondary physiologic effect because the coronary sinus acts as a good capacitor, may not directly volume or pressure overload the right side of the heart, may also change flow patterns through the right atrium and across the tricuspid valve. All very interesting theory. Nothing has been proven yet, but it is the reason that we think that that particular device may hold some unique advantages. And then there's other places, including in the more periphery, to create a shunt. Non-inclusive list, and we saw a couple of these, the Corvia, the V-Wave, you know, have completed initial trials. Corvia is in a secondary trial now looking at a subset that did show potential signal for improvement. Oculotech looking at, and a little bit more used in Europe, looking at some slightly different populations, and now a no implant technique by Alleviant and Intershunt and Noya in there. We can think about intra-atrial shunts from terms of target populations. So HFpEF, you can see a list there of trials and devices that are currently trying to target HFpEF with or without specific hemodynamic criteria, exercise-based hemodynamic criteria to prove that this might be the right population. We have reduced EF populations there. V-Wave did a little bit of both, and then now that both non-implant devices looking at that population as well. And then PAH is a unique population. So from procedural aspect, this is getting better and easier. I think even over the many years now that we've been doing some form of this technique, transseptal stuff, we're getting a lot more comfortable with it, particularly with the mitral valve tier. This is not in left atrial appendage occlusion devices. It's not as scary anymore to walk into a lab and say you got to go across the septum. Our imaging systems are better. Our teams are better at helping guide us to the right place. The catheters and delivery systems are maturing. The sheath sizes are becoming very manageable. But good hemodynamics, I think, are still critical. So now if I put my heart failure hat back on, really getting a good right heart cath at some point, which is like a four-letter word to some interventionalist, you got to understand the hemodynamics before you start poking holes in places. But the concept, again, is pretty simple. I was talking to my college roommate who's now an endocrinologist, and basically the way she summed it up is said, we're just going to return people to their fetal circulation and recreate some basic flow patterns. And hey, it worked when they were babies. Why won't it work as they get older and get sicker?
Thank you. Thank you.
Thank you so much.
Beautiful slides.
Next is a man who needs no introduction. This is my illustrious co-chair, Dr. Fudim from Duke, who's going to be discussing both neuromodulation and cardiac contractility modulation in the next 10 minutes. And then right after that, we're going to go directly into a discussion.
I'm filling in on the, no, clicker. Thank you. Not me. Not me. There's a slide prior to that on neuromodulations that should be uploaded. So as you can tell, I'm filling in for Kunjan Bhatt originally. Yes. That's all you have. What about the neuromodulation slide deck? That's the first talk. Let's upload it online. All right, we'll start with contractility modulation. These are not my disclosures. I would never work for Pfizer. Whereas the concept of contractility modulation, 2019 was actually the second device approved under breakthrough device designation using using the platform of implantable technologies for heart failure with reduced ejection fraction. There's ongoing investigations in the HFpEF space. The concept of contractility modulation is that it uses an IPG, an impulse generator. It is a pacemaker-like structure, 2 leads planted transvenously, cross-tricuspid valve going into ventricular septum, and deliver a pulse that is 200 times or greater that of a regular ECG impulse. So of a regular pacemaker impulse. So it's a lot of energy delivered. You only deliver therapy for around 5 hours out of 24. Kunjan, you are here. Why am I? Yeah, why don't you do your own slides?
I'm not sure I can follow that, Marat. That was pretty good. My name is Kunjan Bhatt. These are my slides. My disclosures and everything has already been listed. So yes, CCM, as Marat stated, is a pulse generator device inotrope. This is an interesting tool that has been FDA approved for mid-range and reduced EF heart failure. CCM, or cardiac contractility modulation, is a device that senses the native heartbeat and follows that native heartbeat several milliseconds later with an electrical impulse in the absolute refractory period that allows the myocardium to respond at the molecular level with calcium without altering rhythm or myocardial oxygen demand. So if you look at the native QRS complex here, on the left-hand side, we're used to seeing that native EKG. To its right is, after several milliseconds, those impulses that are delivered. And what is seen is an improvement or an increase in the contractility force. Currently, CCM is FDA approved for EFs of 25 to 45%, sort of a peculiar range, but that's what the data shows. Functional class 3 despite GDMT and not receiving CRT. The device implant is safe. It is very much akin to a pacemaker. It is not a pacemaker. So this is a dual-chambered pacemaker implant type implant. There are 2 leads placed about 2 centimeters apart in the intraventricular septum on the right side. Complication rates are no different than pacemaker implants, and what has been seen is an improvement in morbidity in patients' symptoms of heart failure. In the interest of time, I will skip over some of my slides. So as Marat had conveyed, CCM delivers 300 to 400 times the output of a typical pacing to capture the myocardium. However, as it's done in the absolute refractory period, you don't capture the myocardium to squeeze, you capture the myocardium to change at the cellular level. Patients receive 5 one-hour therapy sessions spaced over 24 hours. The device needs to be charged once an hour per week, and the battery, the generator itself, can last for up to 20 years. Looking at an EKG on the left, you'll see a normal native QRS complex. And as the initial slide showed, on the right, you'll see in the absolute refractory period, the CCM device taking action. So with the device on, there is an increase in inotropy, as exemplified by this pressure volume loop. And looking at the native cardiac cycle, a pressure time curve, on the left-hand side is an unaugmented beat On the right-hand side, you'll see an increase in dPdt, therefore an improvement in pulse pressure. And on the opposite end, on the relaxation side, you see a negative dPdt improvement, or an improvement in lusitropy. And this is working through calcium mechanisms. So an increase in intracellular calcium is what leads to these findings. But how does that lead to an increase in calcium? If you go back to your biochemistry and cytopathology, this works at the level of the sarcomere and the sarcoplasmic reticulum. Where in heart failure, we see a downregulation of SERCA, and SERCA is closely tied to intracellular calcium. With CCM, there's the opposite effect. There's an upregulation of SERCA activity, and therefore calcium, and therefore inotropy. But if you have these two leads at the septum, what about the rest of the heart? Thanks to gap junctions, these effects spread. So it doesn't just work at the septum, but it starts to spread to the RV, and it starts to spread to the LV and the rest of the myocardium. Interestingly, in heart failure, there's gene expressions that are found to be damaging or harmful. Namely, SERCA is downregulated, and these other genes are downregulated. And there's an upregulation of genes as well, including the natriuretic peptides. And in CCM, these effects seem to reverse back towards beneficial effects. And interestingly, those gene expressions that were seen in CCM have been seen in CRT. So once you place a CCM device at the interventricular septum on the right side, you start to see the effects of the SERCA gene expression effect immediately improve. But if you look further away at the infralateral wall, really no significant gene expression change. But over time, that seems to change favorably. CCM does appear to create an interesting remodeling effect on echo, an improvement in ejection fraction of around 5%, and an improvement in end-systolic and diastolic dimensions also. And that seems to be similar to what was seen in the PROVE-IT-HF paper for sacubitril valsartan. These effects are sustainable. And in the pivotal studies that led to FDA approval, what was seen was an improvement in quality of life and in CPET testing, VO2 max. We say this is a device inotrope, and when you think inotropes, you think of dobutamine and milrinone, and we say those things for durable patients as an outpatient, those are definitely concerning things safety-wise. In CCM, that is not seen. There's no significant increase in mortality or morbidity. In fact, there's an improvement in morbidity. In the interest of time, I will just go to what's on the horizon. On the horizon, what was published and what was actually presented at Madrid in 2022 was a HFpEF pilot of 47 patients. And in these 47 patients, there was a significant improvement in hospitalizations and a significant improvement in quality of life. What's on the horizon for CCM is two trials. There's AIM Higher, which is HFpEF, EFs of 40% or more, and the Integra-D, which is a CCM/ICD combo device. So AIM Higher is EFs of 40% or higher on GDMT. The primary endpoints are listed here. Exclusion and inclusions are listed here. And this is a nice trial to have, as we know that HFpEF does not have a lot. We don't have a lot to offer our patients with HFpEF that's currently on label. In the Integra-D heart failure study, these are patients with HFrEF who have a class 1 or class 2 indication for an ICD and who are not indicated for CRT. This study is going to be interesting because this device has both CCM capabilities and ICD capabilities. So in conclusion, there's an improvement in dPdt and therefore pulse pressure, therefore inotropy. There's an improvement in quality of life, VO2 max, and functional capacity. There appears to be a regression of abnormal gene expression using CCM, and there appears to be an improvement in cardiac remodeling with CCM. Thank you.
You have to present my slides now. All right, sorry for the mishap. Turns out you have to go and actually re-upload your slides in person. You did it online. Same. Thanks, everybody. So I think you will see a long parade of device-based therapies for heart failure, and there's no shortage of them in the pipeline. Not all of them will make it. I'll show you a series of them that are, either in the process of making it to the market, some of them that have not really quite made it. And it's going to be around the broad topic of neuromodulation. Now, Dan tried to earlier give you the physiological background for certain therapies And Dr. Emani, talked about the LA decompression, the concept there of a simple unloading. Neuromodulation is a little bit more complex. The body did not, for a reason, have a very large plexuses all over the body controlling the autonomic nervous system with brakes and with the gas pedal, the sympathetic and the parasympathetic nervous system. The reality is that every organ in the human body touching the cardiovascular system and beyond is innervated with autonomic nerves, and the autonomic tone is disrupted in the setting of heart failure, the sympathetic tone being usually overloaded and the parasympathetic being downregulated. Now, the first device-based therapy that actually made it as an approved device-based therapy to the heart failure market, even ahead of CCM, was actually barostimulation therapy. This is a dial-in to the autonomic nervous system, increasing the parasympathetic tone. It's a unilateral implantation of a device. It's a pulse generator with a lead that goes to the right or left carotid artery. It's external. It's not sitting in the intravascular system. You dial in the parasympathetic tone, and you see the sympathetic tone go down and stay down. That has been pretty well proven in animals and in humans. The Beat-HF trial is the one that actually led to the approval of this technology. It was a randomized open-label controlled trial that hit on all 3 independent endpoints and improved quality of life. NYHA scale, NT-proBNP was improved as well, and they also saw actually an improvement in 6-minute walk distance. Each of those points was hit independently. The FDA approved it. Now, so on the US market, you can market that as this improves the quality of life, that makes you feel better, you will walk further. You certainly cannot make the claim that it will keep you out of the hospital at a greater rate or keep you alive, but the attempt was made. In the second phase of the Beat-HF trial, an additional 40, 50 patients got enrolled and followed all the way up to 7 years with the intent in a post-market approval study to also hit on hard clinical endpoints. That was missed. For CV death and heart failure hospitalization, that's the first yellow endpoints. Having said that, many of the secondary endpoints were looking favorably, indicating an improvement in not only quality of life, but also all-cause hospitalization, all-cause death. Another therapy that has been tested for a long time and is in use for migraine therapies and seizure prevention is vagus nerve stimulation. When tested in the space of heart failure, has only been successful in preliminary clinical trials, but never been shown to be successful in larger clinical outcomes trials that were in a randomized controlled fashion. The most recent one, Anthem, HFrEF, has been stopped for various reasons, but has been only marginal evidence of benefit. Also, a relatively invasive procedure that actually requires you to wrap the lead and cuff around the vagus nerve itself. So a lot more complicated than the barostimulation therapy. We just saw it on the baroreflex. Now, another therapy in the making, this is now all HFrEF in the HFpEF space. We'll talk a little bit about that later, is that the concept of cardiac decompensation. Cardiac decompensation is not always driven, or maybe in most cases not even driven by volume overload, but rather by a volume distribution concept, meaning that there's a vasoconstriction in arteries and veins, leading to a net distribution of blood volume to the thoracic cavity, leading to high filling pressures. Boom, you have the LA pressure elevation that you might pop off of the valve, or you might actually try to stop the nerves that are doing the squeezing and prevent them from squeezing in first place. The catheter therapy was developed by a company called Axon Therapies. You actually do an entire venous procedure going down the azygos vein. You ablate the splanchnic nerves. There are 3 of them on each side. Here you ablate only one of those nerves, the most significant one on the right side, and has been tested in a number of studies. In the most recent RCT, there was really more of a population finding study, was identified potentially a population that will be studied soon in more prospective trials. But I want to make the point, and all the ICs in this room that feel like, well, I don't do much neuromodulation, why is it affecting me? We do neuromodulation in many aspects of our life, in the management of heart failure patients and beyond. Think of renal denervation, one of the first renal neuromodulation therapies approved on the US market. We do that also for sleep apnea. We have the glossopharyngeal nerve stimulation, et cetera, et cetera. So, and there's more stuff coming up in the space where, people often say neuromodulation is possible. It's actually not impossible. We have a number of device-based therapies on that space. Another therapy that's focused on neuromodulation, Dr. Emani is very familiar with this, is the concept of sleep apnea therapy. Obstructive sleep apnea is the glossopharyngeal nerve stimulation, cranial nerve 2. And then we have the stimulation of the phrenic nerve. That's the nerve that stimulates the diaphragm. That's for the purpose of central sleep apnea. It's actually pacemaker-based therapy. Unfortunately, central sleep apnea is not something we diagnose often enough. It's not as common. It's probably less than 5% of the total sleep apnea population, but sleep apnea, obviously one of the life essential aids. We need to identify sleep apnea. Sleep is important, something to think about. In conclusion, device-based therapies are all on the rise. Neuromodulation is not an easy topic just because there's a lot of redundancy built in by our system, not to allow, but the absence of one nerve, the whole system to suddenly fall apart. Having said that, we have more and more therapies hitting the US market, so stay tuned. Thank you very much. Who's taking over?
Yeah, I think that we should skip discussion and probably just go right into the next talk in the interest of time and staying on time. We know people have flights to catch. So we're going to go to our next talk, which is Emerging MCS Platforms by Dr. Basir.
You have another? Here we go.
Thank you. So this is a really exciting area of a lot of advancement and innovation. So I will quickly go over 45 seconds to a minute of each of these devices, and I think we're going to get into a little bit more of the details of some of the platforms that are currently available. These are my disclosures. So the first new and novel pump is the Impella ECP. It's probably the most developed of the new pumps that are available as of right now. It is a 9 French device, so it is the smallest French access that we have available to us right now. And it expands to about a 24 French platform and basically is able to provide slightly higher flow levels than an Impella CP, so very consistently at around the 4-liter mark. It is designated specifically for high-risk PCI. I can tell you in working with the device that this current platform will not be utilized in the cardiogenic shock space. Maybe some other technological changes and innovations will occur to allow for that, but this current device will be for high-risk PCI only. The EFS study was already been completed, and in fact, we can say that the pivotal trial has been completed as well, and it is waiting FDA approval for a commercial release. So in total, 256 patients were enrolled across 18 sites. We were one of the sites that were included within the trial. There was a 30-day MACE rate of around 6.3%, which was significantly lower than the performance goal of 24.4%. There was no major hemolysis, no significant aortic valve injury, 1.6% risk of major vascular injury, and 5.9% risk of major bleeding. So this is the significant improvement within the complication rates that we've seen from other large bore hemodynamic support devices. The next device here is the Magenta device, or by Magenta Medical, the Elevate device. So this is a 10 French over-the-wire device, very accustomed to placing it very similarly to an Impella CP. It expands, however, to 30 French, and this is the largest device that we actually have available in terms of the impeller itself. And so it gives mean flows consistently of over 5 liters and peak flows as high as 8 liters. And so this is actually purpose-built for both high-risk PCI and for cardiogenic shock. Perwaiz is not here right now, but he was involved in the EFS study, which is now completed, and the pivotal is underway. There's nobody been randomized, but 3 sites are all very near conclusion of their IRBs and SIVs as well. So there's been so far 20 first-in-human patients, 8 patients that were involved in the EFS. For the Elevate 3 trial, they're going to include 290 patients across just over 30 sites, most likely, with a 1-to-1 randomization. And what was really interesting about the trial design here is they actually allowed for comparison to Impella ECP as well, which really shows you what they think of their product, that they're very comfortable, comparing themselves against an ECP for non-inferiority as it relates to MACE and safety events. So really, really interesting device, in my opinion, probably the most competitive device available because of the size and because of the amount of flow that's available within this device. A similarly very interesting device that I think has a really strong opportunity to make a lot of headway is the Supera device made by Shifa Medical. So this is also 10 French over the wire, and it expands to about 22 French, very similar to the Impella ECP. However, it gives slightly higher flows, so consistently in the 5-liter range. It is also purpose-built so that it will be first trialed in high-risk PCI, but their plan is to also utilize this device in cardiogenic shock. The EFS included 15 patients, and if anyone knows exactly, they're either just about to be completed or completed, so very, very close. But they also, most importantly, raised $120 million for their pivotal trial. And so this is really, really, something that is going to be starting within this year, if not next year, for Supera. They did publish their case series on the first 30 patients at THT this year, and they have up to now 70 patients that have been mostly treated in South America, where they've been doing their primary research both in Paraguay and in Brazil. The next device is the Cardion Cori P4 system. We're utilizing this device in terms of a trial design as well. This is a 14 French device, so not a smaller platform. It also provides just above 3 liters with maximum rates of 4 liters of flow, which is interesting, right? Because this is as big as an Impella CP with kind of similar, maybe slightly less flow, and it's also purpose-built for high-risk PCI. They've done 30 first-in-human studies. The pivotal is actually currently enrolling and has enrolled in more than 50 patients already. The overall trial will include 280 patients, 40 sites. It's a 1-to-1 randomization comparing to Impella CP, and it's also a non-inferiority trial. The Vitalis device by Boston Scientific is a 14 French 4-liter device that is a purpose-built for high-risk PCI. There have been 5 first-in-human cases, and the EFS has started, and the pivotal trial is pending. It's very, very similar to an Impella ECP. And the last couple of devices are not purpose-built for high-risk PCI or cardiogenic shock, but for cardiorenal syndrome. So the first device is the Aortix device. We've implanted more of these than anybody else in the world that I'm aware of. It's an 18 French device that provides 3.5 liters of flow. It's purpose-built for cardiorenal syndrome and patients with advanced heart failure. The EFS included 18 patients, and the pivotal is ongoing. This device sits in the descending aorta. And a similar device is the module puzzle medical system device that can be put in through a 10 French sheath. The case example I'm showing you is through a 14 French sheath. It's also a cardiorenal device. This is, they've done 3 first-in-human cases in Georgia, and it can actually basically have multiple devices within the descending aorta and provide anywhere from 6 to 10 liters of flow in the descending aorta. So even though it's not purposefully built for cardiogenic shock, you can imagine the opportunities that potentially are there. And I won't reiterate this point, but there are new durable LVADs that are now available as well that Dan mentioned earlier in the talk. And because Jen Cowger is leading the study and she's my partner, I had to put this slide in. So. In summary, though, this is really, really an area of a lot of innovation. The devices are smaller, they're much more powerful, and they're soon to be evaluated by the FDA. So there's a lot of growth within this space overall. Thank you.
Thank you so much. Our next talk is one of our lightning talks by Dr. Faraz, who's going to be discussing the ECP device.
Thank you, Michele. Thanks, Babar. Are they pulling up? I did upload the slides in the speaker ready room. All right, guys, so good morning, and thanks to the directors of the program. So I'll be highlighting a clinical case on an ECP. Dr. Burkoff and Babar talked about ECP as the device when they talked about newer devices because it has the largest clinical experience. So in the space of high-risk PCI, the contemporary landscape and limitations, right? We all know that the elephant in the room is the vascular complications related to large bore access. And I think that has been the primary driver of outcomes. We saw in the danger shock trial, vascular complications, renal failure, dialysis were extremely high. And in spite of that, the device showed that there is a mortality benefit. But this is something as a clinician, as an interventionalist, I think that is the Achilles heel, is large bore access management in itself, which is why the impeller ECP system came into place, because the concept was to shrink the device into a 9 French introducer sheath. The device itself is temporarily compressed. The pump itself is a 21 French with an external motor drive to the impeller in the LV. It's a wireless delivery system, unlike the CP, which you cross across the valve. It has a soft atraumatic cannula. I will share a clinical case. And the device itself has shown 2.7 to 3.8 liters of average flow, with up to 5.5 liters of peak flow in systole. And I recently had a case last week where a patient was hypotensive at the start with multivessel disease, and I was really surprised of mean flows of over 4.5 liters, which was amazing. So again, I have decent amount of experience. We have at Hackensack done over maybe 60 cases with ECP. And the more I have utilized the device, the more I have started to believe that it will be the new kid on the block. So the flow rates vary based on the afterload. It's a load-sensitive device. And as you can see, at different pressures, the device can augment itself. And that's something once you start using the device, you will learn that the afterload dictates the flow, and the pressure volume loops are slightly different for ECP versus CP. So I'm going to start with a clinical case and try to wrap it up in the next 2 minutes. This is a 63-year-old patient transferred to our facility to the CT surgery service for CABG evaluation, had a distal left main bifurcation, low EF, transiently required some pressors, but was taken off, and then subsequently we had enrolled him into the ECP. So this is a peripheral aortogram showing really nasty aortoiliac bifurcation disease. You can see the left common iliac and external iliac. Again, this is what precludes these patients from getting large bore access and drives the complications. So this patient, in spite of having a nasty aortoiliac bifurcation, was successfully had an ECP pump. The device itself goes through a 9 French sheath. We call it hatching of the device in the descending aorta. And in the left slide, you will see as the device comes across, it's going to hatch out there, and then we're going to cross the aortic arch and the aortic valve. Now, horizontal aortas are particularly challenging. Operators who do TAVRs understand the challenges of deploying a TAVR valve with a horizontal aorta. So this is a case where we actually showed that in spite of a horizontal aorta, we were able to successfully cross the valve without a wire. So again, I think you need to be technically advanced in terms of being able to understand how to manipulate your pigtail with a wire, but this is a nice case illustrating that the device can be crossed in spite of some anatomical challenges. So again, the case, I'm not going to go into the details. DK crush acrobatics, cross, recross, wire, kiss, port, final kiss, but had great results. This actually is highlights what happens when you inflate the left main. And you can see on the right hemodynamics where your aortic pressures have completely flatlined, but your mean arterial pressures are maintained in the 60s and 70s. And I think that's what, as clinicians, as operators, what we want is to maintain the maps. And this case highlights that the device is doing what it is supposed to do. Again, the device gets resheaths back in the aorta, and then it's removed. So this is the resheathing of the device and being extracted out. So Babar talked about the clinical safety and secondary outcomes. This has been presented earlier in the last year by Dr. Kaki, which showed that it met its primary specified safety outcome, which was around 6%. The decided number was 24%, so it had almost by a margin of 4, which is very impressive. In terms of vascular closure, majority of the device was closed by an 8 French angioseal with very, very minimal vascular complications. This is our Hackensack experience we presented last year of large bore access. Our own vascular complications were 25% with a CP. And with a targeted approach, we brought it down to 3.5%. I think that's where the 9 French devices will play the role. This is the device with the largest clinical experience, over 500 patients. And if you combine all the other MCS devices, I don't think we have patients in 3 digits to compare them. So that's why I think this device is probably the promising technology. FDA PMA submission is ongoing right now in review, so we will be very soon hearing the approval. In conclusion, the MCS use is on the rise. Patients are getting older, more complex, more calcified, more turned down by surgeons. And these are the very patients who benefit from MCS, but they are the very patients who are going to have complications. The device has shown benefit with the CP in these patients, but at a very high vascular complication rates. And I think the ECP, the 9th French, will address vascular limb issues, hematuria, and potentially it's the future of standard of care for high-risk PCI. Thank you.
Thank you. So next will be Dr. Meraj, who will be he's back. He had to jump in another room quickly. We'll be talking about the Magenta platform.
Yes, thank you. Sorry, I have to go next door for a quick IV talk, but I'm back. All right, good. Thank you very much for the opportunity. Let's talk about... Works. Clicker is not letting me go forward. This one? The big one, right? There we go. Okay, there we go. All right, so we're not going to get into details. We have 5 minutes to do a talk. I don't want them yelling at me on the other side of the panel there. So we know balloon pump. We have all the Impella family of devices. We got Tandem Heart and Protect Duo, which are used less, but they have their place. Supersaturated oxygenation. Interesting concept. We don't talk about it, but it's not an MCS device, but it may have some role in this. ECMO, and there's so many combinations, right? So let's talk about some of them. So what we all want, we want something that's smaller. We want something that has more flow. We want something that the surgeons don't have to put in. We want something that's put in under 5 minutes. We want something that's very easy to use because, as someone mentioned earlier, we're just interventional cardiologists. We're very simple-minded people. ICU-directed care by hemodynamics, obviously, and we want fewer complications. As Haroon said, access site complications are the kicks of death for a patient that's already sick, and we don't want hemolysis. Pretty simple, right? Okay, so the future's here. So we got some new kids on the block, right? So I'm not going to go into Supera. I was asked to focus on Magenta, so we're going to focus a little bit on Magenta today. It's a 10 French device put in with a regular 10 French Terumo over-the-counter sheath, so nothing special. So no tricks and games with inner diameter, outer diameter business that everyone likes to play. And so once the sheath is in, you essentially treat it like any 10 French device. You put it in over a wire. I think that's where some of the differences are over ECP. It's a wire-based, so you can probably manage more angulated aortas a little bit more easily. Once it's placed, you unsheath it, and I'll show you the video. It unsheaths to about 30 French, that tube. So it goes in completely closed, and it gets unsheathed across the aortic valve. This is the actual impeller technology. This is what it looks like when it's compressed, and this is what it's expanded. Hopefully the one on the left will play right after this, otherwise I may have to click it. There we go. And the beauty of it is that, this is the part of the problem. You need the impeller is probably big. The bigger the impeller, the better the flow. The smaller the impeller, you're going to need to RPM it higher to cause more hemolysis. And so the concept is, how do you make the impeller smaller when you're putting it in? And that's what they have sort of figured out. This is what the sheathing looks like. It goes from 9 French to 30 French. It's pretty simple and impressive, actually. That motor cage and the impeller itself sits in the LV, and that's the end pigtail over there. We did the cases in the original EFS study, and I have to tell you, it's about as simple as it gets. I was actually shockingly impressed how simple this device is to use. The difference between that and other devices, and again, this is not we're not here to sell the device, right? We're here just to look at differences and see which one is better or worse, or what we can learn from all these devices. And I think some of the things that we're learning is that, this impeller needs to be compressed, and the expansion, the bigger it becomes, the better it is. And I think that's an important factor in flow and complication rates as we move on. This is the working flow inside each of these devices, right? You see 30 French for Elevate, 23 for the 5 and 5.0 and 5.5, which should impress you because that's currently the gold standard of what we're doing in shock. right? And then you have Supera, which is 21 to 22 French, similar to the Impella 5055, and the CP, which is 14 French. And so, but the Axis Sias is only 10 French. So you have to find, this is sort of the holy grail if this actually pans out, is you want it big inside the body, but you want it small going in. This is the flow. This is the peak flow and the mean flow. You can see here, we're not going to get into all these details. Comparison, you guys all have access to the slide. Since I only have a minute left, we're going to actually get to a case. So here's an actual case of ours that we did. You can see here, someone with a low EF has a defibrillator in place. This is the placement of the device. This is how it gets unsheathed. And then you'll see here in the last video, this is now it working. You can see the device actually in the LV, pumping through and running. We did a high-risk PCI. This is, like I said, part of our study. We did a bifurcation circ. We did a LAD. And then when we were pulling it back into the system, this is what it looks like coming back in. Similar to what Haroon mentioned with the ECP, it gets resheathed in the descending aorta. Pretty simple, pretty easy. The whole thing comes out, the 10 French sheath is left in place, and you close it however you want. Whether you pre-close it or you post-close it, that's your call. These are all of the 18 cases that were in the EFS study. You can see here the mean arterial pressures for every single patient that's listed. And our case example is someone with a CTO, 3-vessel disease, EF of 20 to 25%, a pre-existing heart block, and the patient developed AV block. And this is the actual tracing from their monitor system, and it actually shows what happened. And you can see here, when the heart block initiated and the pressure dropped, we had to ramp up the RPMs to actually go to full flow. And at full flow, you can see here we're getting mean flows of 5.7 liters per second, per minute. Per second would be impressive, per minute. And the patient was fine. Nothing happened. It was very easy to use. And it's similar to a lot of these percutaneous LVAD devices that we've seen from the original Impella days. You're able to actually take care of the patient very easily. If this pans out in shock, with even a higher gradient across the valve, right, and better hemodynamics, this is a percutaneous 10 French LVAD, right? And so that's pretty impressive. So 15 patients, 18 total that we did in the US EFS study, no hypotensive episode, no device adverse complications, no clinical meaning hemolysis. Obviously, every single patient's alive and well, and still today we still follow them as part of the trial. As mentioned, there's a high-risk pivotal study that's hopefully starting next year, and I think there'll be a cardiogenic shock first-in-human study starting as well soon. The future is bright. It's just, and I say this every time because I got asked to talk about devices for the last 10 plus years. It's not about the device. The device is part of the armamentarium, but let's not make it all about the device. You need a good device to take care of the patient acutely, but it's the management after that that is so much more important. Teams, protocols, centers of excellence are absolutely critical. You can have the best device in the world, but if you can't get a patient to get it in there, then it's... and really look for the data. I think the data is going to be coming out, so thank you very much.
Thank you so much. And wrapping up our session is going to be Dr. Alvarez, who's going to be presenting on Supera, and then we're going to head right into the discussion.
Okay, thank you for having me. I'm going to talk about the Supera PVAD. Similar device to what has been mentioned until now. Is it the big green button? There you go. I have no disclosures, that went quickly. So this is an overview of the Supera PVAD. As was alluded to before, what we look for is a device that has a low profile, high flow, stability, hopefully in the future patient mobility as well, but these devices are all aiming for those goals. So this is a depiction of the Supera device. It's also a foldable device delivered through a 10 French axis. It's a proprietary sheath. It's able to deliver 5.5 liters of flow. It has an atraumatic tip. Importantly, the aortic outflow is way removed from the aortic valve, which limits the chances of hemolysis through that mechanism. It seems to be pretty stable and flexible. And it has sensors like the Impella CP now in the aorta and in the LV, which allows us to get direct pressure measurement. It's delivered over the wire. These are some pictures from the early feasibility study that was done in Brazil. Also gets unsheathed in the aorta, and it tracks over the wire into the LV. This is the console. It's a touch screen. high resolution, and it allows you to get all the parameters that you need. And the current indication is for less than 4 hours for high-risk PCI. This is an overview of the timeline of development of this device. So in 2022, there was the first in-human experience in Paraguay. 2023, they got FDA breakthrough device approval. And 2024, they published the result of their 50 patients in Brazil in the outside of the US early feasibility study. And ongoing or just completed is the US early feasibility study, and upcoming will be the pivotal trial. This is the first in human experience. This was presented at THT, and 14 patients were treated in Paraguay. Half of them were done with a regular 12 French sheath, and then later they used a proprietary 10 French sheath in the rest of the patients. As you see, it's a pretty standard patient that we see for high-risk PCI. We don't have a lot of information about what the coronary anatomy was like or the coronary treatment that was done, but we know the EF was mostly preserved in these patients, although some of them exhibited, or all of them exhibited heart failure symptoms. 93% had a procedural success, and there were no device-related complications. In the Brazil experience, which was much larger at 2 centers there, they treated 50 patients, similar demographics, and also similar paucity of data regarding the coronary anatomy. There was a case that was shown in this presentation at TCT. All patients with heart failure symptoms and a little bit of a more reduced EF. The support time was about 80 minutes, and most of them were male. So this was, importantly, a clinical events committee adjudicated outcomes at 30 days. So although there were some bleeding events, none of them were attributed to the device itself, but rather to secondary access or the PCI or other issues. So there were no major vascular complications attributed to the device. And there you see some events like stent thrombosis due to interruption of DAPT, MI, etc. So in the US early feasibility, this was presented at SCAI last year, or this year, sorry. There were 15 patients presented in this experience. They enrolled more patients since then. Similar demographics as well, EF around 46%, and the support time was a little bit longer, 109 minutes. There was 1 arrhythmia, but no sustained hypertension, and 1 death, and 2 BARC bleeding events. In the published data, I didn't find information whether this was attributed to the device or not. That's a quick overview of the Supera. Thank you very much.
Congrats, you're the only one that stayed on time. All right, we are now here for our discussion portion. Any questions from the panel? I know we had a very broad array of technologies we discussed. Also, audience, if you have questions, please shout out. So, with this competitive landscape, actually just curious, because we have the same situation. If you were getting approached for all of these studies that are going to the pivotal high-risk PCI, how do you choose which study to do? Because most of them are still in the study space. How do you sign up? You just go by bigger is better or smaller is better? What's the decision making there? Curious.
I actually think that there's a lot of value in being involved in more than one study. We were involved in 3, EFS, Cardion, and Magenta. And I think they are all different platforms, and it's nice to be able to understand the advantages and disadvantages of each. But you have to have enough of a robust clinical program that you could support that. And you have to basically talk as a team and say, hey, listen, rather than us being the top 1 or to 3 enrollers in one of the studies, let's be medium enrollers in all of the studies, but have a better vantage point of what technology is best utilized by us for our specific center.
And what do you see as the role of the heart failure docs? This is supposed to be interventional heart failure. Now, the last few talks were very IC heavy, but what's the role of the heart failure doc currently or the next gen of devices?
Yeah, I mean, I think ultimately it's keeping us grounded, right? I think, all of these are going to come out in the high-risk PCI space because it's easiest to do that going forward. But after they get high-risk PCI approval, many of these devices will want to go into the cardiogenic shock space, it is significantly harder to show that a device will do well over a number of days rather than a few hours. None of these devices have been shown to actually be durable enough to stay in a patient for 5 days yet, right? So these are really, really important things, and I think the heart failure community needs to keep the interventional community grounded when all of these toys do become available, and ask ourselves the same thing that we ask ourselves when we put a CP in heart failure shock, right? Like, why did you do that? Why didn't you call a surgeon? Why didn't you get a 5.5 in? All these other questions.
Yeah, I'd love to tackle that one. I'm not just the token female or color on the stage here among all these dark suits. I'm an advanced heart failure cardiologist, and I do my own procedures, which is increasingly rare in the heart failure space.
And your name is Dr. Hall.
Huh?
Your name is Dr. Hall.
Yeah, Shelley Hall. And the reality is we watch these trials, we consider them the kindergarten for getting to college, which is shock. You need to do it. It takes a long time, and they're not all going to make it. And we watch it with, extreme interest. We're looking, they're saying how they don't want to have a surgeon in the mix. The heart failure space says we don't want an interventionalist in the mix, because how many Friday transfers do we get who've had Impellas for 5 days now in renal failure and now being asked to try and save them. So I very much echo, it is very difficult to get these devices moved quickly into the shock space. We need them in the shock space. It's way too expensive right now in the shock space. We end up removing the CPs, putting in 5.5s, or they crash and the kidneys fail and we're putting them on ECMO, and then we're trying to find a way to salvage them. The pathways right now, the federal regulatory pathways to try and study devices in shock are too onerous. They're too critical. They do force through the PCI pathway first. And even your ECMO devices are forced to go through cardiopulmonary bypass OR trials to show they could be used in the OR as cardiopulmonary bypass before they can get into the shock space. So, we have a huge patient population that needs this technology, but it's very, very slow to get to us.
Well, so then the next question to the durability, maybe you can take that. Are they going to be durable enough for, Dr. Hall, how long would you want to have it? What's your ideal time frame for keeping them in?
Now, obviously, we divide it into durable and temporary, and I think, as in everything, we keep cutting the pie smaller and smaller, and I think there's going to be these intermediate duration devices, is what we consider the 5.5 now, that can last for weeks or months. I think part of the technology we know, getting rid of the pigtail is key for durability. That causes too much hemolysis and arrhythmias. So any device that has a pigtail, it'll have to be modified to get into the intermediate space. The larger the bore, the better for decreasing hemolysis. And then, of course, the ability to keep your vascular access as small as possible, so that patients can ambulate. And so the ability to eventually do percutaneous axillary is going to be a huge jump for this space, because we are talking about recovery a lot in the ICU, and that ability to percutaneously access the upper body, have weeks of support with low risk, and ambulate and rehab a patient are going to be the keys for postoperative recovery.
Yeah, so I think let's go back to your first question for 1 second. So the team aspect of this, I think the man next to me is probably the preeminent expert on this area. Babar and company have really shown that those of us who did this back in the day, when we were only an interventional cardiologist taking care of these patients, realized that we didn't do a great job, because we were just doing things based on just what we saw in the cath lab, and then there was nothing after that. We're in the cath lab. We're not sitting in the ICU all day taking care of the patient, right? So that didn't work. So the heart failure doctors also need to have partners to be able to do these crazy things in the middle of the night when they need help from us. And we need help from the surgeons, because there's still devices that the surgeons need to, help us with. And we're not there where we can do everything ourselves, right? The 5.5 device is not a interventional percutaneous device right now. And that's what we have today. So if you look at the landscape today, the team we still need the team. The team can't be disbanded. The team must exist. And I think his outcomes show that the team actually has made things better for patients. So the team is very important. I don't think that team should ever go away. And I think the working collaboratively together is really important. Who does what, I think, is less important. I think it's more important how we treat the patient. That's one. Two, you talk about durability. Every company is going to want durability results, right? Because they're all buying for this. So they're all going to be looking to see durability. If you speak to them privately, they've all have bench studies with these devices running for weeks and months. Doesn't mean it's going to be the same in a human being, but they all have device, models that have been running for months, and durability is there. And also, anyone who's involved with the FDA knows that the FDA gives you a 6-hour window originally. Remember from the original Impella studies, they were all like 4 to 6 hour windows, but they needed bench data proof that it was going to run a lot longer than 6 hours. And so in order to get the approvals, you need to have a certain amount of bench data that shows that the durability is a lot more hours that you have. So the durability will be there. You're absolutely right, as Dr. Hall said, you need alternative access to be able to ambulate patients. In a pinch, obviously you put these things in femorally because you just fast. But honestly, axillary access doesn't take that long, and if you're facile at it, and this is where, again, collaboration with people who do this every day makes it a lot easier, right? But if you want to have access to the devices, access to the care, and access to patients anywhere in the country, anywhere in the world, it's a whole different conversation than having it in either Detroit, New York, or somewhere where in the big cities where we have access to everything. And I think that's important to understand the graphics. So the systems of care, moving patients to bigger centers, how do you manage these patients after the device gets put in, the funnel where they come from, AMI shock, which is most likely going to go for recovery if done properly, versus heart failure shock, which is a whole nother spectrum of patient. They're not the same patient, and the team aspect is totally different. So I think there's a lot of, it's very heterogeneous. You have to really take care of the patients that way.
As far as your question about which device trials to pick, I think it's important that the devices that gives you the largest amount of cardiac output, so 5 liters, I think, is the magic number. Shelley talked about it, and I think the limitation right now is having a percutaneous femoral access versus axillary access. I think the future will be the interventionalists would have to train themselves to get a percutaneous axillary 9 French, which can give 5 liters of support. And I think that's where these devices, so we have picked Magenta and Supera as our second and third parts to be part of the pivotal. So we get experience with 5-liter devices. We are transitioning into trying to be more percutaneous axillary with that mindset that in long term, if durability requires in patients in the ICU to have an axillary access as opposed to a femoral access.
So Haroon, do you think that these, and all your interventionalists, do you think that these devices can make the angle from the axillary to the innominate back down? Can they make that turn?
I think with the with over-the-wire technology, yes, we can definitely do it. As the 9 French ECP technology, I personally haven't done any axillary. Yeah, but
that's an important.
But I think, yeah.
That's an important question.
But that's a good food for thought. Yeah.
I mean first on the bench, the companies can test on the bench whether and in animals if it can make that turn. It's not that easy. I don't think it's an easy turn, right? Does it? If it's.
I'll tell you, advancing the 5.5 is so much easier through the upper body than the 5.0 was with the big pigtail. Its ability, it's a shorter cage, there's no pigtail. You can make some very interesting turns with that device that we couldn't do with the 5.5. So I think that will be part of the technology change.
So,
No, I just had a comment that it seems that placing, if these devices were intra-aortic, we would, annul a lot of the problems that we're having. Stability, hemolysis, interaction of the pigtail with the LV. And these intra-aortic devices were kind of mentioned in passing, but they can be pretty powerful. Do you think that physiologically that could be an alternative to have a intra-aortic 5-6 liter per minute pump? It could even be placed bedside in an emergency.
Intra-aortic instead of yeah. I can just tell you that I think physiologically they won't do the same thing. you really need to be in the ventricle to pump from the ventricle out. There is this durable VAD called the MyVAD. Maybe some of you saw it if you were at Gordon or whatever. It's not a percutaneous device, but it sits in the aortic root and is continuous flow, but it doesn't go into the ventricle, but it is pulsed. So it only pumps when the aortic valve is open. So that's the idea. I mean, you need to, maybe one of those devices, if they synchronize, I think that there's a potential. But I think you really need to be at the aortic root or in the ventricle to get that unloading that you really need, don't you think? The unloading is vital.
I want to move actually to the other topics we had earlier in the talk, and asking Kunjan Bhatt here. So, we as heart failure docs, will we ever take center stage and have many of these devices being utilized? Because right now, with CCM Barris, in my experience, we don't get many referrals for them. We use them, but not many referrals. And, the shunts are coming our way. Like, what will it take to change the mindset for these things to be utilized more often? Just as often as Impella is getting popped into everybody these days.
Marat, thanks. And again, thanks for the invitation. My biggest challenge, I think, to present to patients, I firmly believe that device therapy, neuromodulation, cardiac contractility, intra-atrial shunting to be determined, but these other two devices that you and I discussed, I think in select patients can be very helpful. The challenge I see is patients have a lot of device fatigue. So many patients with neuromodulation or with Barostim, they already have an ICD. So they have an ICD. We're offering them a second device on the opposite side of the chest. Patients get fatigued. I think it's, and when you're talking about device therapy and you're talking about morbidity and not mortality, it becomes a tougher sell for patients. That being said, there are motivated patients out there who feel terrible. And I think it behooves us to make decisions with patients, not for patients. So it's all about, we say this and it sounds cheesy, but it's true. It's shared decision-making is key. That we present patients an equipoise position of this exists, this is in trials. We give them a menu. And I think you and I have discussed this, that when you come to see me, you're not coming to me for a pat on the back and shake your hand and see you in a year. You're coming to me for an extensive GDMT, what's on the horizon and what's in clinical trials. And if I don't do that, I didn't do my job. So I don't think it's meant for everyone, but I do definitely think that there's a niche of patients that we're missing. That niche is not small, but it takes a motivated patient to want to do this.
I would take a little different spin on it and say it's not so much patient resistance, but physician resistance. In the primary care and general cardiology space, they don't mind getting the patient a defibrillator because they don't lose the patient. They get the defibrillator, the EP goes away, they never have to do anything again, and they get to continue to treat the patient. Just like we continue to rail against, we don't get our advanced transplant VAD referrals early enough in the space. Now you're talking about a stable early class C patient who tells the doctor they're fine, and we're asking those to get referred for an intervention that we are going to manage, and therefore the immediate, I'm not going to lose my patient to heart failure pops up. I think it's a referral problem, not a patient problem.
I want to give a third perspective, which is especially for CCM and BAT, which is unlike CRT, where you don't have any reservation, right, about preferring. Neither of those other technologies have the outcome data that has really driven the adoption. CRT was approved in 2001 based on patient-reported outcomes, but did not really have a real uptick until they showed the mortality and hospitalization data. So I know for CCM, there will never be a randomized trial that's going to look at outcomes and hospitalizations, mortality and hospitalizations, because it's just too expensive, too large. However, and I don't know about CVRX if they're going to do an outcome study. It's very hard to do these trials now. But I know for CCM project that we're working on is to use real-world data to demonstrate the impact on mortality and hospitalization. So we have a really cool project going on, which I was mentioning before, on using the Truveta real-world database. Truveta is a database that has 120 million lives covered in the United States, with access to, not only claims data and reporting, but actual clinical, characteristics and data. So you can start doing kind of trials in silico using real-world experiences. And so we have an abstract that we submitted to HFSA on our current results, where we look at CRT in a real-world evidence to look at whether CRT saves lives, and in similar, using the same methodology, whether CCM, its impact. So I think that we're going to have to look at different alternative strategies for doing clinical trials in the real world, because there's too many devices, too many things going on. And with the FDA becoming a little bit more lenient with this breakthrough device designation pathway, where you can actually get an approval based on patient-reported outcomes, you can't get adoption and guidelines, inclusion in the guidelines. That's the other thing. CCM and CRT are not really in the guidelines. So these are, and that is an obstacle for reimbursement. So, it all feeds on itself and relates to what does the community really want, is that those clinical outcomes. Well, there's efforts to talk about that, but
I had a comment about that because I've used CCM and Barostim in my practice. I think that we should be offering these technologies to the most desperate patients. It's like TAVR in the beginning, right? We weren't using it for people who could choose between surgery and TAVR, or low-risk patients. And we shouldn't post these technologies as a marginal symptomatic improvement to people who are tolerating quadruple GDMT. We should post it as a patient who can't tolerate GDMT. I know this is not how they were studied, but this is a potential for uptake of the technologies. You send me this patient, he can't take RNA because of CKD or whatever. I put CCM, they feel much better. I reduce hospitalizations and bring benefit. And then from there, we could potentially expand to more mainstream.
Well, I think inadvertently, those are the patients we do those procedures in, because
Exactly.
they're the only ones we have. So I actually come back to Dr. Hall. So do we need to democratize access to these therapies? I mean, I'm sort of prepping myself. The shunts, let's say, get approved a couple of years. Who's going to be referring for those shunts? Who's going to be referring for Barostim, CCM in the future? How do we increase or change this referral problem?
Boy, that's a very, very big question. I think we're antiquated. I mean, I've been doing this a long time, and we haven't changed our approach to how we make guidelines in 30 years. And we need to evolve beyond just the hard mortality data. Patients want to have quality lives, not just quantity lives. And I think that we need to readdress how we look at all this stuff and get it into guidelines sooner, get it to more patients sooner, because we can't afford to do the trials that everybody is mandating anymore. We can't do it.
there is a little bit of an effort at HFSA to address this with Javed Butler and some others have been tasked with such a thing to discuss it. I don't think that HFSA alone can change that, but at least to publish some scientific statement about this, and it's going to be taken up on a scientific statement that's going to also be discussed at the CVCT meeting in December. So hopefully a publication will come out of that, and maybe there's a way to but it's really a tough thing because insurance companies don't want to pay for PROs at this point. They want to pay for things that matter to them. I mean, to that they see that's hard endpoints. I don't know.
Well, thank you so much to all of our speakers and our panelists. We're going to take a short break, and then we're going to regroup with our next talk starting at 10:30. So half-hour break, and then we'll return.